So he'd poke the peritoneum with his finger, incise the sheath with the knife, and once he's completely in, he's not started the gas as of now. Gas start कर दिया? नहीं तो पहले कैमरा डालो, पहले कैमरा डाल के देख लो. Once you see your inside, then you insufflate. The only problem with this, which I feel, is because VRs say it goes at 2.5 liters per minute. Whatever the speed is there, it can go. So the pneumo can go up very fast. So he can have bradycardia. This is perfect. Perfect. Now he has made sure he's inside. If needed, take a purse string suture. 30 degree. Okay. So most of the case, I think he would do with 0 degree. At the bladder neck, I think he would switch to a 30 because for the circumferential, you have to see down below. So that's what I also do. I do most of the whole of the case with 0 degree. And if I'm doing a circumferential bladder neck dissection, I switch to a 30. So he's had a laparoscopic attempted converted to open mesh hernia repair. So I'm hoping the mesh is from the outside because it's not there inside, just some bowel adhesions are there. So yes, this is the tab block he's waiting to show all of you, if you can see on the big screen. So the idea is to take the needle between the internal and transversal. So what you do is you go up to the peritoneum, then you withdraw a little, and then aspirate and then push. If you're in the right plane, a bleb of muscle will rise. If you can see that the bleb of muscle is rising. If he was in the pre-peritoneal plane, only the peritoneum would have risen. And if he was in the between the external and internal, no bleb would have formed. So if a bleb of muscle is coming up, he is in the right plane. Ashwin, what do you say?
And also it's diffuse, it's not localized. As you can see, it's very diffuse, so you know it in the right plane. If it's very localized, it's peritoneal.
So this gives amazing pain relief in the post-operative period at a tab block. So 20 ml on one side. Now when he comes to this side, he'll give the 20 ml on the other side. So where the muscles fan out, just beneath the rib cage. On the rib cage, just beneath the rib cage.
So the classical description is sort of at a triangle that is between your latissimus dorsi, posteriorly, and the external oblique. But that's for an ultrasound guided tap. Usually for an endoscopic tap, the best thing to do is to put it higher than your highest port, because it gives a block this way, not this way. So you want to put it as high or higher than your highest port.
It will be all down below.
Yes, it's a caudal block, so it doesn't go cranial. So again, you can see it's quite diffuse. It's not a localized bleb. And it's going sort of transverse. The whole infiltration is transverse.
So the first port was about 2 finger breadths above the umbilicus. So in cystectomy, we go a little higher up, 1 finger breadth more, because we have to do a lymph node dissection till higher up. And we do intracorporeal bowel anastomosis, so you want the instruments to be very high up. Here, 2 finger breadth above the umbilicus is the first port. Next port is again 8 centimeters, 1 finger breadth roughly. If you can see, external view dikhana camera mein dikh raha hai, dikhao. So 1 finger breadth externally, just above the umbilicus. It all depends how the patient is. If the patient is very big, the umbilical line is fine. There are some adhesions, Ashwin. I think you'll have to do some adhesiolysis. Left pelvis. So this right port that he put was for the hot shears. Now we use 2 assistant port, one 12 mm and one 5 mm. 5 mm is for the sucker, 12 mm is for the hemlocks and the clips. I use 2 because I want both his hands to be assisting me at the same time. A lot of people use only one, then only one of his hands is useful. So this is the 12 millimeter port, which is coming in about 2 centimeters or 2 finger breadths above the ASIS. ASIS, 2 finger breadth above, 12 millimeter port. All the hemlocks will come through this. External view dikha sakte hain. So this is, yes, this is a 5 mm port. This is an isosceles triangle between the camera and the scissors.
I mean, you can modify the port positioning, however you want. If sometimes when the patients are very big, you've got a lot of space, and when you insert patient, you can't release the pelvis. So, or if patients are very narrow pelvis, then it's probably not something you see as much here, but we see a lot of pelvis after therapy men who've got a very narrow pelvis. Then what we tend to do in both very fat and narrow pelvis if you do a double configuration. This is very much like an R, but then we end up doing a W, so you have the camera here, the first round, and if you have an air up here, it does this and this, so it does a W configuration. So you've got a small patient or a very large patient or a narrow pelvis.
So like an SI, an old SI port placement.
Yeah, very similar to that. And also we've sort of done a lot of modifications. So I mean, I don't use any clips at all during surgery. So I just use 5 ports. I don't usually use 6. And obviously, the people who make the air seal have come up with a 8 mm air seal through which you can get a sucker in. You can even get needles through it. So you can do 5. Because one of the most painful areas is this port. Yeah, the problem with the air seal is the most painful for most patients. And you can avoid that way.
So we also tend to put our fourth port little higher up, that if the patient's pelvis is narrow and if the fourth port is too lateral, it will go and ride over the vessels, the pelvic vessels. So that would be dangerous for the patient. When we are moving the prostate up and down, we will ride over the pelvic vessels. So that's when we will realize, once we put the camera, we see how the pelvis would look like, and then we also try to put our instruments and see. If it's too lateral, it might run over the vessels. So that probably we can modify.
And this is a good check that he's doing here, which is making sure the ports are at the point of pivot, which is the band that you see there. That thick band has to be at the abdominal wall. So this is a good check to do just before you start operating, just to make sure you're not too in or too out, or you haven't hit mesentery, you don't have any bleeding and all of that before you start. And sorry, I think your question was, you put it on the right or the left? It really depends on, so you can operate any way. So you can, if you have your pro grasp on the right hand, your assistant is going to be on the left side, and the 5 mm port is going to be on the left side. If you're operating with the pro grasp on the left, which I do most often than not, because I like scissors in my right hand, then the assistant's on the right, 5 mm on the right.
We do on the right side.
You have the pro grasp on the right
fourth
side.
port would be on the right side. Why? The only reason is basically we are trained on it. That is one. Second is because we feel like two grasping instrument would be on your other hand. For example, one side would be a bipolar forceps. In your right hand would be the scissors. And fourth port, it all depends upon how you are comfortable. But if you put a fourth port, that's according to us, on the right hand side, if you toggle the instrument, two grasping instrument can be with you. If it's on the left side, then two grasping instrument, the bipolar as well as the progress would be on the left side. So that's the only reason why we do on the right side.
Why don't we have a robot with the 5 arms?
There are robots with 5 arms, but there is no even if they had 5.
Because we have a system code, so we can have a.
So Mantra has 5 arms, but even I don't think nobody ever uses it.
We've tried with
no
mantra.
space.
We've tried with mantra doing that. It's really difficult to dock
There is
5
no
robots. Those are singular models. So it's very difficult to
There'll
dock
be a lot
them
of
all 4 or 5 models.
external clashing that will happen.
I mean, the question is, what are you trying to achieve with extra arms?
See, as she's saying that we have an edge when we have a pro grasp on the right side,
Yeah.
but why don't we have a option of having both sides, right?
Well, so I think you can only control 2 arms at any given time, right? You can't control more than 2 arms. I mean, so when you do with a dual console sometimes, 2 surgeons can control all the arms. So those sort of operations where you've got more than 1 surgeon, you can have more robotic arms. It's not possible at Intuitive at the moment, but any of the multi-modular systems like Medtronic, CMR, all of them, you can put how many ever you want and control. But when you can do the operation just with 4,
We need a one trained assistant, like you have a Parveen
Yeah.
here.
yeah,
If we don't have a Parveen here,
yeah.
then
No, that's a very good question. So, but then you can't, but then you can't control it, right? Because if your one hand is constantly doing suction, so for example, a lot of the cases when they do with single port surgery, they use a suction drain which is very heavy. So the suction drain always sits at the bottom. It's called a sump drain. And when they're doing that, they don't necessarily need an assistant. You still need someone coming your instruments in, needles in, all of that sort of thing. Say again?
Actually, it's a very nice device. We loved it. We used it recently. 1 day prior, 2 days prior, we did one radical prostatectomy. We used it. We enjoyed it. We don't have to suck like
but you see,
crazy.
all of those things are adding costs to your operation.
Yeah, so that we avoid.
But then you would need air seal with it all the time. So that's another added cost. We are already pushing our costs so high. I think everything you add on for your comfort.
so many robo coming in the market, I think cost is going to reduce now.
Do you have
It's
anyone from
already
Intuitive here?
reduced, sir. So we are using Edge Robot. We have 2 at the moment.
Where
So
is
one
Archita? Archita, are
it's
you going to
almost
reduce the
like,
cost?
Da Vinci. It's more than 90% like Da Vinci. It's not the same, obviously.
The
but
what,
it's
sorry?
almost the same.
The discussion.
Movements are also
Okay.
almost like the Da Vinci. The
Okay.
motion
So I asked this question exactly to Dave Rosa. Do you know Dave Rosa? He's your CEO. So I asked him, what are you going to do about it? You got Edge, you've got Medtronic, you've got all of these. The microport system is probably 60% of the cost of the Intuitive system. And then the single thing he said, people who buy Ferraris don't buy Ford even if you drop the price. So, you could have discussions how much ever you want. The price is not going to drop. And that's coming from their CEO. They won't even do that. So, I mean, I love Intuitive, and I've worked with Intuitive very, very closely for more than 15 years. But I think what's happened a little, I mean, you've got the X here, which is great. You've got people who go for the DV5 and the SP. It's becoming more of an Apple-type architecture. I mean, how many of you have iPhones? Probably everyone. So every 2 years, or 1 year or 2 years, new model, you buy a new one. Nothing's compatible. It's not really compatible with the previous things. So that's how it's sort of going. But I mean, there is no, I mean, I know you spoke about Edge, Kinju, but there is no system that comes even close.
I
in
totally
terms
agree.
of
I totally agree to
accuracy,
say,
in terms of efficiency, smoothness of operating compared to this system. And when you run into difficulty, I think that's what you want at the end of the day, to give it the best to your patient.
No, so we used to have Da Vinci SI, then moved over to X. Now we have X and we have Edge.
Ready?
So we have both. We have both, but we tend to select our cases. All the pelvic cases, all the cystectomy, prostatectomy, radical nephrectomy we do in Edge nowadays. And complex partials we tend to do in Da Vinci.
So I think an important thing here is to also, when you dock, I mean, they obviously did a very seamless dock, but when you're doing a dock, a couple of things. This side, perfect for me. This side, can you move that elbow out for me, please? So it's very, very important when you're using, I mean, when you're using the XI, it doesn't make a difference because it obviously automatically docks, it does all of that. But then when you're using systems like the X, you want to have what's called the elbow to be complete. So in terms of energy, I have the monopolar shears on the right, the Maryland forceps on the left. In terms of energy settings, for the monopolar, I prefer the forced setting compared to the Swift. I feel it does much better.
Ashwin, I have a question for you. Have
Absolutely.
you tried the classic setting?
The classic setting I have, I find the force the best. It's sort of, you can do it at a low setting, although I have set it at 4 at the moment.
I don't know if this is, I think it is just my perception, but I moved to Classic 2 a long time ago. I think it mimics what the Valley Lab or Covidian energy systems do.
Yeah, probably.
So
I
I
think
agree to that. Why? Because now, again, the edge system I'm talking about, but in edge they don't have their own energy devices. So we use Covidian. So and when we use Covidian, when we use the cautery setting, like how we use it, the cautery works like, it cuts like butter. It's very good.
Yeah.
so. This is probably why they couldn't put the hernia mesh here.
Yeah, some adhesions there. Yeah.
So this is, I'm sure Ashwin would say, this is, even if you don't have additions here, getting the sigmoid out of the way is the way to begin the procedure.
Yeah.
If you don't do it, the whole thing, if it's not just set up right from the beginning, and then bowel is coming in your way, the assistant has to constantly retract. I think Kinju and Ashwin will both agree.
Yeah,
If our assistant in a good robotic surgery, if your assistant is constantly having to retract stuff for you, then I think exposure is not good, right?
Yeah, absolutely. So I think yesterday at dinner we were talking about redundant sigmoids in Indian patients because you have very redundant sigmoid wanting to go into the bladder.
It should be the other way around, don't you think, Ashwin? Indians have a lot of fibers in their diet. So
Well, I mean, that's a very interesting point. They should, and certainly I think what we do see is patients who have a predominantly vegetarian diet do not have a redundant sigmoid. But obviously, you know, even in India, the diet is changing to a point where you probably have a lot more people not having the traditional vegetarian diet. So things change.
So even if you, I would say even if you don't have this amount of adhesions, a good thing is to mobilize the colon until you see sort of the psoas muscle on the left.
Absolutely, yeah. So we'll sort of talk about the landmarks of mobilization in a little bit. I tend to mobilize it all the way to the line of Todd. And that's so that so he's got some internal herniations here. Now, with these internal herniations, I tend to leave, if there's a bit of fat plugging it, I tend to leave that fat plugging it. That sort of works as a mesh repair type.
This step, I think, is if we are planning on doing pelvic lymph node dissection later, is very important.
Yeah,
if we
no,
don't drop
absolutely.
it down.
Yeah. Although in him, you know, I wouldn't do it. I think we were talking about this, Kinjo, a little bit earlier. In the United Kingdom, we've completely moved away from doing lymph node dissection unless it's part of research. We've had so many patients. I mean, I'm primarily a cystectomy surgeon. I also do prostates. And my lymph node dissections are very, very extensive, pre-sacral, all the way up to the IMA. So I wouldn't sort of do a half-baked obturator node dissection, and that probably takes me an extra half an hour in the operation.
I think that is what the guidelines also say. If you're going to do a lymph node dissection, just do an extended one.
Yeah.
Yes.
And I think so. Anyone who is doing a half-baked node dissection, and so I've seen 2 cases like that where we had to go in and do they had a recurrence just in the nodal packet, and then it becomes hell when you go and try and re-resect that area.
Yeah, no, absolutely. So get it right the first time. That's a very sort of common theme within the National Health Service where I work in the UK. It's all about getting it right the first time. If you have to go in salvage things, you're always giving less than ideal outcome.
Dr. Rahul, can
Yeah.
you hear us there?
Yes, perfectly. I also wanted to ask Ashwin.
Yeah.
So, in the UK, I believe the decisions about high-risk prostate cancers depend a lot on the PSMA PET scan findings.
Yeah.
So, if you do have positive lymph nodes on PSMA PET scan, that patient is preferentially sent for radiation and hormone therapy rather than have a radical prostatectomy. Or, I mean, at least it was that when I was there a couple of years ago.
You're
in my
absolutely right.
hospital.
I think the evidence of lymph node involvement suggests there's micrometastatic disease, and there certainly isn't evidence then of removing just the prostate or even removing the lymph nodes. I mean, the evidence for lymphadenectomy curing N1 disease is in a very small select group of patients who have less than 3 lymph nodes and probably Gleason score 3+4. Even if it becomes a primary pattern 4 within the prostate with lymph nodes, then it's not going to help. So what I might do, because I'm dropping all of this anyway, is go completely extraperitoneal at this site because it is quite adherent. I don't want to inadvertently cause injury. So this is perfect for an anterior dissection. So these are the sort of landmarks that you want to have. So I'll let go of this again. So this is your urachus, medial, this is the median umbilical ligament, medial umbilical ligament, one on each side, and your lateral umbilical ligament here, you can see the epigastric vessel. That's your lateral umbilical ligament, your deep inguinal ring. So he's got an obvious hernia on the right, but it's not going all the way through, so they've probably fixed the right. Don't know what they've done to the left. It doesn't look like they've fixed the left, but I don't want to go into that.
So I have a question here.
Yeah.
How do we assess the mobility of, and how do we assess how much to mobilize the sigmoid here?
Yeah, so as long as it's safe. So if, I mean, I am going to go extraperitoneal and mobilize it anyway. So that's why I don't want to go between this and go here as well. That's a waste of time and setting yourself up for disaster. So the line for dissection to doing the anterior is you've got your median, I've got my progress on there. This is my line of dissection going all the way lateral to the medial ligament. I tend to start, I don't start in the midline because what I tend to do is preserve the urachus. So we can see if we can do that. And I'm going to excise this. I'm not going to incise the deep ring.
Yeah, so this pull with the progress here helps a lot. It's all about traction and counter traction. So once you pull with the progress, the medial umbilical ligament, you'll get a plane, and we can develop a plane in between.
Absolutely.
Here we can see the vas as well.
So you can see the vas there. I tend to take this all the way down. And because we're not doing lymph nodes, I'm not going to take the vas necessarily. You can take the vas if you want to, but I'm not going to take it here in him. It's not going to add anything. So the moment you pull it again, so just let go and pull it again, the air does the job for you. So again, going down the same plane. And the hot shears are meant to work with an open blade and not a closed blade. If you use hot shears with a closed blade, then you tend to fuse and get lesser use out of your scissors. So you want to do this with an open blade.
Ashwin, once again.
Yeah.
So I think everybody who is attending today, I think rather than watching what his right hand is doing, I think pay attention to what his left hand is doing, because right hand is just removing stuff. Everything is being done by
here,
the left hand.
I absolutely agree, because we tend to say the same thing to our fellows. When we started learning earlier in our years,
So you've got the traction here.
how to use our left hands.
So counter traction here, and then incise.
See, his left hand is again giving that traction. Both his left hands are giving him traction and letting him know where to go.
So this is the slight advantage opposite to what you were talking, Kinju, about having the prograsp on the right. So having the prograsp on the left allows you to do this. Now, if I was doing lymph nodes, I would do lymph nodes before I would do the prostatectomy. I would take the vas, I would do the lymph nodes and go down this way. But because I'm not doing it, I'm just going to go in this plane. Now, once you've made that incision, you're sort of trying to think, where do I go down here? And you see fat, cobweb, fat, vessel. So what I tend to do first, Maryland, push the bladder medially. It just opens up for you nicely. And then you just incise within the cobweb.
A very good plane comes up, so we can simply push it away and then we can reach and we can see the bone there.
And you do this and it goes all the way down to the endopelvic fascia. So all I'm doing is sweeping away down and medial. So I'm not doing any of this lateral sweeping, because if you do lateral sweeping, you run into troubles with the pelvic sidewall, whether they have accessory vessels, whether they have small, large veins, whatever. You run into those sort of issues. So what I'm doing, very importantly, pulling the bladder away, incising in the midline. So I'm not incising laterally here, pulling the bladder and incising. So then all my dissection is where I can see rather than where I cannot see. And now you can see the endopelvic fascia that has sort of come up already. He's got a very small prostate. It's only 25 cc. He doesn't need too much lateral dissection here to free it up. This is the bladder. That's the prostate. And if you go more lateral, after you open the endopelvic, you'll see the lateral rectal space, which I never open. I don't open the endopelvic fascia at all. And you will see that you don't need to open it. Hopefully I can convince you of that.
I absolutely agree to that. We also don't open endopelvic fascia. We believe that if you preserve a lot of tissues surrounding the urethra, including endopelvic fascia, which will help you later to do the anastomosis anteriorly, we feel that the continence might be better.
Absolutely. It's about preserving that whole mechanism. And then you can reconstruct as well. So we'll do a little bit of reconstruction because we are going in the anterior technique. You go through, that's the DVC there. You go through the detrusor apron. And because you're going through the anterior detrusor apron, by definition, you are disrupting a part of the continence mechanism. And hence sort of developing the Retzius sparing technique. I've got the auto stop on the Maryland, and the auto stop is it tells you that you have completed the diathermy, because if you don't have the auto stop on, then you're not completing what you have to do. So this is now midline, left side. So I know I have done all of that.
So
Ashwin,
what additional advantage do you feel that preserving the urachus provides in this approach?
So preserving the urachus, to me, what it does is it allows me to not have anything to have traction on the bladder. Otherwise, I end up putting a bladder retraction stitch. So again, because the prostate is very small, I don't think I need to do it. But in him, if he's got a lot of adhesions and I just have to do it, I'll do it. But it's something that, it's again going with the sort of the principles of doing the least that you have to do, rather than, just opening up because you need to open it up.
Ashwin, can I just add something to this answer?
Absolutely.
Yeah, so the other surgeons that I have seen who preserve the urachus, they say that if you're not doing, if you're doing an anterior only approach and the urachus is still attached to its anatomical position, so once your surgery is over and the patient stands up or starts walking about, the bladder goes and sticks to the anterior abdominal wall in more or less a similar anatomical position it would have been had it not been mobilized.
Absolutely.
So in patients in whom you have cut the urachus, if for some reason you're doing a post-operative cystogram to look for leak, you would see that the bladder is kind of fallen down into the pelvis in a bunch.
Yeah.
But in patients in whom the urachus is still intact, it stays upright and sort of a more anatomical angle of the vesicourethral anastomosis.
You're absolutely right. I think that's perfectly correct.
I think also, so I also don't drop the urachus. For the last maybe 200 prostates, I have not dropped cut the urachus. I started doing it because I noticed when when you preserve it, nothing comes in your way. So your assistant cannot accidentally bring bowel into the field. He cannot accidentally bring fat into the field.
So I am sort of incising into the epigastric vein there, because I don't want to go lower where the bowel is. Well, we can suture that up. That's not a problem.
And I did miss the first part, so I'm not sure where the camera port is, but I have seen some surgeons place the camera port in a paramedian location,
Yeah.
just so that they can go through that window which is created when you preserve the urachus and get around it.
Yeah, no, absolutely. So you can. I mean, it really depends on sort of where you are, what anatomy you're encountering. So this is, you don't usually go into this space. This is very, very much superficial. His posterior fascia is completely obliterated with his
Previous
adhesions.
surgery, yeah. He's undergone a mesh repair.
So this is probably why they abandoned his laparoscopic hernia repair.
Maybe
he's
we
got
can
some,
suture that vein.
He's got some aberrant vessels going. We'll try and spare that because you don't need to incise it. We'll see where we get to here.
Would you not want to clip the vein that you have cut?
Yeah, so I'll suture it. So I won't cut it. I won't clip it. I'll suture it. But what I want to do is make sure I don't suture it and cut it again. So I'll really try and release this completely. So it looks like this, his bowel's going completely into the hernia here.
Ashwin, what is your opinion on patients? So a lot of our patients have, I would say 50% of them have a hernia.
Yeah.
What is your opinion on repairing the hernia at the same time as a prostatectomy? Now, the reason I'm asking this is twice I have been in a very tricky situation where we left it.
Yeah.
So basically, we are making something what was extraperitoneal. Once you
Yeah.
drop the bladder, you're making it intraperitoneal. And
Yeah.
both my patients had obstructed hernia needing.
Yes, it shouldn't be. It shouldn't be the bowel. So that's what we'll sort of cut slowly, see where we are.
These must be the gonadal vessels actually.
No, you don't get gonadal cyst. So this is your inferior epigastric that I've incised there. So
Gonadal-
that's fat.
That's the
That
deep inguinal
looks
ring,
like
right?
Yeah.
testicular.
You're right. You're
Testicular
absolutely right.
So coming back to that question, what is your opinion on
Hernia.
repairing the hernia?
It depends on how wide mouth the hernia is. So if the hernia is wide mouth, then repairing it with a prostatectomy is going to sort of narrow a protective hernial orifice. So I would not do it. If it's a very narrow hernial orifice, then I would put what's called a shuttlecock mesh in, extraperitoneal, and then close the peritoneum over.
So this must be the vas actually, no?
Yes. So this is the vas here.
So the hernia, regarding the hernia repair, we used to leave it before. So since last 2 to 3 years, we've started doing mesh repair at the same time. Yeah,
And
we
you've
finished the
not
radical
had-
prostatectomy,
So-
we do it with the composite mesh and we
Madhav, so have we discussed the approaches? Because Ashwin is doing a completely anterior approach, I believe.
Yeah.
Have we
Yeah,
discussed
so the
what we would normally do, what all of us do in our respective places of work?
No,
So-
no,
so
no.
Madhav, what
we
what do
did
you
that.
got?
We discussed that in the morning class. Yeah, but we can again revise.
We can
yeah.
revise for whoever's
Yeah.
not here.
Yeah.
So let's start with Kinju. Kinju, what do you
So,
do? Anterior,
we-
posterior, HCS
We
pairing?
regularly do posterior first, solely because we have fellows to train, and for their training purpose, we start with posterior dissection. That is one. Second is because we have a lot of our cases are a lot of locally advanced cases, all T3 and above T4 cases. So we are comfortable doing posterior dissection first, mobilize all the seminal vesicles, and then we drop the bladder.
Okay.
But for organ confined, easy cases, we just go anteriorly.
Rahul, what are you doing?
So I'm doing laparoscopic prostates at the moment, and I have to do a posterior first approach for the very reason that most of my cases are T3 huge prostates. But when I was trained, I never have even seen a posterior approach, except in some cases where there used to be a large prostate, and one of my proctors used to just open up the posterior peritoneum, saying that whatever bleeding happens when you are doing the bladder neck, that just trickles down and goes posterior, doesn't collect there. So that's the reason why we are doing this posterior, raising the posterior peritoneal flap. Other than that, I have never done, even in laparoscopy, I do it completely anterior.
Right, can I have a needle holder in number
Ashish, what do you do?
So,
What do I do?
Ashish, good morning. We didn't see you.
Yeah, good morning. So I do both radius and combined posterior and anterior.
Okay.
So now that we are doing a lot of
Yeah, so just
after neoadjuvant hormone therapy, I always believe that doing a posterior dissection in such cases is very
Thank you.
is a good approach actually.
And it
Because
doesn't take, it doesn't even take much time. 10 minutes and 15 minutes we can finish posterior dissection.
Yeah.
So I have never done a posterior approach. I have never done a radius approach. I was trained anterior and all my I have once gone for an anterior because there was an emergency and the surgeon had to leave and asked me to take over, and he had started posterior. So for 5-10 minutes I was very lost, thinking what to do. So I just converted it back to anterior and finished it. But I think Kinju made a very valid point. If you have trainees, it is much easier to train them for the bladder neck when you do it posteriorly.
Yeah? Nah, it's all right, don't worry. This bit should
you
be
have
okay.
the luxury of being at Max where you can.
That is
use
very true.
these two.
That is very true. If I'm struggling, I will, but seems to be okay for now.
What would you do, because now Praveen brought this up, what would you do in London? Would you use 2 needle drivers? Would you use the...
So I think when I'm dealing with venous bleeding, I don't use 2 needle drivers.
No, I'm talking about for the
anastomosis?
anastomosis.
Yeah, the whole case I'll use, well, it depends. If it's an easy case, I wouldn't use 2 needle holders. But for most of the cases I do are either salvage or very nasty cases. So that's why I tend to use 2 needle holders. If I'm doing a radius sparing approach, I will use 2 needle holders simply because that gives you much better control for the angles because you're using 2 arms to do the anastomosis. Majority of my cases are radius sparing, so then I would do it as 2 needle holders. The reason I don't use 2 needle holders when you have venous bleeding is because the needle driver is a horrible instrument to hold the vein. So say if I have to compress and hold the vein or hold the wall of the vein, then I will have 1 needle holder to drive and the other needle holder to manipulate the vein. So whether it is a sort of a small venous ooze like this, or whether it is an IV, a sort of an external iliac, internal iliac ooze, I would always use 1 Maryland, because with the Maryland, I can grab the vein. Needle holder, you cannot grab the vein, it'll tear the vein.
That's a nice learning point for everyone. But I think in India, because of cost issues, I would say 95% are just using a single needle driver, including me. I have only used a double needle driver once.
I've never used a double needle.
Where my patient was, yes, because you're at Max.
You're at Max.
You're at Max. So when I use the double needle driver, I've just become so used to using one that I used to, and I was unable to do it, and I said, just give me back what I normally use.
Right. What is the pressure at, please? Can we get it down to 8, please?
Okay, because we are, I was just going to bring this up. Ashwin just asked about the pressures. What pressures is everyone using? Rahul, Kinju,
So let's just have
So we
irrigation on
use,
this from here.
8 to 10.
and are you using air seal for every case?
No, we don't have air seal. So the case that I described was in a different hospital, not there.
Okay. And Rahul?
I have used air seal for every case during my fellowship. After that, I have been doing laparoscopic prostates.
No, I'm
So-
talking about the pneumo pressure. What pneumo pressure do you
12.
Okay. Um,
And I raise it up, obviously, when we are doing the DVC. I go up to 20.
So I think we can all go back and try doing it at 6. It really works. You don't need air seal. You don't need nothing. There's nothing different. And the reason I am saying this is because there was a day I was not operating. I was sitting and watching. My mentor was operating, and I noticed the fellow who's on the bedside is always sucking. Even if you set the pressure at 15, the pressure is never actually at 15.
Yes, I agree.
It is always
Yeah.
at 8
It'll come down, yes.
naturally, or your port will be leaking. In India, we sometimes reuse a port. It is always at 8 to 10.
Yeah, so all of my
but-
operating is at 8.
But Madhav, here I differ in a little bit in terms of putting a pressure at 6, especially when we are doing posterior dissection, and especially when the pelvis is narrow and if we are using cautery, and if the pressure is at 6 and if somebody is sucking there from the bedside, that way your the
So,
abdomen falls down.
So for
I don't know about-
defatting, I tend to sort of follow this technique always, which is to pull the fat up and then diathermy, because a lot of people diathermy on fat like this, and if you've got anterior disease, then that will give you a positive margin. So it's important to start from lateral.
And is it your routine practice to send this for?
Yes, but that translates to early bowel recovery. So all my radical prostates are at 6. If I feel it is a little difficult, I will go to 8. All my nephrectomies are now at 8 to 10. And it really makes a difference. The anesthetist is very happy.
Ashwin, will you send this fat for biopsy?
I will, so I'll send this fat for pathology. He doesn't have anterior disease, but whenever you take something out, you send it.
So do you send it all together, or do you send it in different packets?
It's just all together. I mean, it depends on how it opens up, to be honest. It can open up.
I'm saying, will you send this along with the or you're not going to do a pelvic node?
No, I'm
here?
not doing lymph nodes, no.
But say you were doing a pelvic node, what is your general practice? Do you send
Send it separately.
right and left?
Always, yeah. I always send it separately, right and left pelvic. But when I do an extended, so you're sort of so this is now skeletonizing the sort of superficial dorsal vein. This is what bleeds. So we'll bipolar it distally. So with the lymph nodes, I tend to send right and left. If there is a very odd lymph node that we are taking away, say for example para-aortic, or whether it is sort of common iliac or presacral, sometimes when the pet is sort of equivocal.
Sorry,
then-
Ashwin, I'm just cutting you off here. So, but for everyone who is seeing, he was just controlling the superficial DVC.
Yeah, the superficial
And
dorsal vein.
he did not cut it distally. The reason is, if it starts to bleed, you will not be able to control it.
Yeah, and then it goes into the DVC.
It goes inside. So you coagulate it and then cut it proximally. So even if it bleeds, you have a stump to take control of. And especially when you're starting out, the bleeding tends to happen here, and then I see people using a lot of energy trying to control it and packing it with gauze. So the easiest way is cut towards the bladder neck. Coagulate the whole thing and cut towards the bladder neck.
Yeah, so control distally and then cut proximal. That's absolutely right. And also the other common problem that a lot of people do is taking the prostate fat. You end up taking bladder fat. So if you are getting big vessels and that's bleeding, that means you're taking bladder fat. Prostate fat shouldn't really bleed. Yeah, you can hold that. Thank you very much. And it's important your assistant does that because then you can bipolar it again. It's all about controlling the vessels before they bleed.
So just a small question, sir. Like
Yes.
we were discussing about the superficial DVC.
Yes.
So we tend to cut it more towards the bladder neck. So are we planning that we are leaving some amount of fat on the DVC? Not, we are not planning to bear it completely?
I mean, you will never go at that level for the apex.
Okay.
You will see our apical dissection is going to be here, not there.
Mm-hmm.
So that because of that, you don't need to really go too much toward the apex. So all this operating is to ensure that they have good functional recovery.
Okay.
No, I think in the era where we're not doing lymph node dissections, I don't think we should be, it makes any difference if a little bit of fat is left.
Yeah, absolutely. You're removing the fat not for oncological reasons. You're removing the fat to allow you to visualize the bladder neck a little bit better. You can
It's
take that
purely
out and then you can
technical.
come back for this.
Yeah, I tend to remove the fats on the lateral side also, just purely technical, because when we go posteriorly and try to go up for the pedicles, the
Yeah.
fat will disturb you. So removing it up front now only helps.
Can you take that as well for me, please? Can we warm up the 30-degree lens, if that's okay, please? So I'll swap. So this is where I tend to go from 0 to a 30. Or if I was just using a 30, I would go from a 30 up to a 30 down. Now, the landmarks for your bladder neck, you can see the edge, which is the arcus tendineus. And this is the fat. So I'm going to start sweeping the fat away. What you want is fat leading to more fat. You don't want fat leading to bladder or fat leading to vessel. Is the 30-degree lens ready, please? Okay, let's change to a 30-degree lens, please.
So Ashwin, is this your routine practice, starting with 0 and then switching to 30, or?
So my routine practice is actually not doing an anterior prostatectomy, but if I do an anterior prostatectomy, I will, it depends on what scope's available. If you've got a 0 and a 30, I'll start with a 0, more so because you've got sort of adhesions, you want to get your bearing right, and then I'll switch to a 30 to go 30 down. But if it's a very straightforward case, then I'll sort of just stick to a 30, and I do a 30 up and 30 down.
And I don't know anything about Retzius, so I'm presuming when you do Retzius, you need 30 up.
Yes,
Yeah.
so for a Retzius prostatectomy, I mean, no, you don't necessarily need a 30. Increasingly, I'm doing most of my Retzius just with a 0-degree lens, but I think the 30-degree lens is more for patients who we want to definitely do a good nerve spare, then you need a 30-degree lens.
Kinju, what do you use?
So I think use of camera is purely personal. Whatever we feel like, I switch between 0s and 30s. Depends upon the procedure. Bladder neck always 30, posterior 0, apex 30. It all depends.
I wouldn't
Ashish
change
and,
after getting to a 30
Rahul,
here.
30 or 0?
Very good assistant who knows where to point it. Yeah.
So I think it's important to have both on the table. I do all the case with 30, but there are, again, somebody was discussing, I think Ashwin was discussing those African patients we get a lot of, where the pelvis is really narrow and then anastomosis becomes difficult. So I only sometimes switch to 0 for the anastomosis, but otherwise I would do the whole case with 30.
So this is another important thing when you do the bladder neck dissection. Your prograsp has to be close to where you're doing it. A lot of people will put the prograsp somewhere here on the bladder, pull it back. That it's okay, it's not bad, but it doesn't give you the ideal sort of way of doing it. So you can see, yeah?
Ashwin, may I suggest that you show them all the ways to identify the bladder neck?
Okay, so one of the ways, obviously, the classical way of doing it is by doing a catheter bounce. So let's do a catheter bounce, please. Yeah, all the way in.
So just for the audience, he's pushing, the bedside assistant is pushing the catheter all the way in first, and then he's going to tug.
So this is sort of, we can see the balloon of the catheter coming up till here. So tug back again, please. Out. That's it. So you can see the groove there.
So again, for the audience, if the patient had TURP done, sometimes we tend to inflate the balloon bit more. So sometimes 15, 20, just to understand where the bladder neck would be.
So because this is a small prostate, what I'm going to do is I'm going to start with a medial incision here just to release this to start with, so I get a little bit more traction.
So again, at this point, I would recommend everybody watch what his left hand is doing.
And I see a lot of people doing this. So one of the first things I teach fellows when they come to me, operating with me, is the bipolar has to face the sort of the perineum. It doesn't face the, it doesn't go horizontal. Because what happens if you keep your bipolar like this, the whole thing you can see gets pushed there. Whereas if you keep it like this, then you get better traction. So that's what I'm doing. So this is my lateral extent. I don't want to go into this vein. I'll try and avoid it as much as I can. If I have to go, it's a small prostate, so I shouldn't have to do anything there. So I'll go medial to it. So you can see the posterior apex is here already, although I think I might have to take this here, so I'll take it here. Again, buzz it distally first.
So this is the area of bladder neck what always bleeds, I think, for everybody.
Yeah.
And one more thing I'd like to add, I don't know whether Madhav you do it or not. Dr. Ashwin, what I do is when we start with the bladder neck dissection, I reduce the brightness a little bit. So that the, when we cut the bladder neck, the shininess.
The brightness of the screen? Oh, I have never
the
tried
camera.
that.
So that is what has been taught to me by Dr. Raghunath.
Yeah,
so
that's a trick we used to do in the SI. We used to always reduce the brightness a little bit. It's not something we tend to do with the XI or the X. So you can see how this is sort of telling me to go here. This has got a vessel here, which I don't want to touch yet. You've got the elastic fibers of the bladder, which is here. So I can go lateral here. So again, trying to just piece it away, see how it goes. And I'll go slowly here. I'm not going to rush. And then I know that that's safe, and I know that this is bladder neck, so I can release a little bit more.
So for the benefit of the audience, he's just opened up the plane between where the endopelvic fascia is meeting the bladder neck.
So arcus, which is the edge here, endopelvic fascia, not opened, fat here. Now, if I had done a posterior dissection, I probably would have met that there, but I haven't, to try and demonstrate how you can do it without opening the fat.
I think as long as we are seeing the fat, we are safe.
Absolutely. You're in the fat, you're safe. So you can see fat, you're safe. Importantly, what my Maryland's doing is pushing this way, pushing the bladder away, protecting the bladder. I don't care about the prostate at this time. What I want to do is protect the bladder. So we'll sort of give short bursts of energy, make sure, like I said, fat is leading to fat, and it's not leading to vessel or to bladder. So this is, again, fat leading to fat. I can see more fat here. And like I said, as long as, if you get a little bit of bleeding, you're okay, because this is where the veins are, around the bladder neck. So that's fine. You're okay. You can control it quite easily with the monopolar.
Ashwin, when we do this, there are a bunch of veins what we encounter.
Yeah.
Just to make it simple, do we have to be medial to the veins or do we have to be lateral to the veins?
It depends how big the prostate is, to be honest. So if the prostate is very large, then you have to be lateral to it. You can't afford to be medial to it. But if the prostate is not too large, then you can afford to be medial to it. So you can see how my dissection was initially going there, but because the prostate is not very large, I can move the bladder neck, and I'll try and go in as close as I can. Fat, elastic bladder. Okay? So it starts always with protecting the bladder. You see fat here, so I can, again, short bursts of monopolar. Use the scissors to sort of separate the tissue between the fat there. You shouldn't get into too much bleeding. I mean, you can always get into a lot of bleeding, not that you can't, but you shouldn't get into too much bleeding if you are separating the tissues with your scissors, because it's a fine instrument, so separating with the scissors. And this is still fat. This is not posterior detrusor apron yet. And I'll show you when we get to posterior detrusor apron in a bit. So this is still fat. I'm okay here. So using my Maryland is constantly doing this, pulling back. This is again fat, cobwebs. So this is now, I can see that I need to release it a little bit medially. So this is what I meant by doing the dissection posterior to anterior. So I'm not going down like this, but rather I have identified the base of the prostate, which is here. Just back with your socket a little bit.
Can we just request you to please clean the lens, because it's a little smudgy for us to appreciate.
Okay, fine. Cleans the lens, please.
So while they're cleaning the lens, we would appreciate if the audience has any question for Ashwin or any of us. Because the more interactive this is, we'll enjoy it more. Any questions from the audience?
Yeah, that's fine. You can clutch it there for me.
Okay, so as there are no questions coming from the audience, Ashwin, my question is, if you keep going into this plane,
Yes.
you're going to hit the vas, right?
Yes, I'm going to hit the vas and SV.
Vas and
Absolutely.
SV, yeah?
Yeah. I will. So what I'm coming across now, under here, is you can start to see the posterior detrusor slips, white elastic, fat. Okay? So spreading that again, going under the posterior detrusor slips, and you can now see that I'm coming across some structures which are opening up, and that will lead me to the vas and SV. So you can see there, white for vas.
Very nicely.
Yeah, so now we're gonna do sort of posterior to anterior dissection. So I'm gonna hook, so this is why I like the Maryland. I can hook the bladder, lift up, and then away from the vas, and then go from posterior, try and get to the base of the prostate.
So my question is, do you always follow this technique irrespective of where the disease is in the prostate, or for patients where the disease would be in the base of the bladder, would you modify this part of the dissection?
So you can see a flare of bladder on the prostate. So I'm not right on the prostate.
Yes.
So even if you have basal disease, you can do this.
Okay.
So, but obviously, I wouldn't suggest you do it, probably at the start until you try and understand where you are.
Okay.
But it is certainly something that I would encourage everyone to sort of try and get into the habit of doing as you take on more and more complex cases. So I'll stop there on the right because I've sort of finished the right posterior lateral dissection. And then again, you see muscle going on to prostate,
Yes.
fat laterally. So I'll incise it there.
Dr. Ashwin, do you, I'm sorry, I am not unaware, do you do Regius sparing?
I do, yes.
Okay. Sir, so in this, in cases where the disease is at the base, are you more comfortable with the anterior approach, that you are able to preserve the layer of detrusor on the base as compared to Regius, or what is the technique that you use in a Regius sparing approach to leave out some fibers of the detrusor on the prostate? How do you do that?
That's a very good question. It's a very advanced question to answer. The simple answer, I would say, is if your lesion is anterior base, it's easier to manage it like this. I wouldn't say this is the only way of doing it, but it's easier to manage it like this. If your lesion is posterior base, then doing it Regius is easier. Does that answer your question?
do you think it is the other way around? If it is anterior, I would be more comfortable with radius, and if it's posterior, I would be more comfortable anterior.
No, because when the disease is posterior base, that is when so when you're doing the retius and the disease, you start with the vasa, SV, you can go wide,
Yes.
and you can handle the posterior base easily.
Okay.
Because you're incising it first, you can go wide. The problem with the anterior base in retius is that you only see it after you do the bladder neck dissection. And because you see it only after the bladder neck dissection, that's where you run the risk of going into the prostate.
So what anatomical landmark you use during a posterior radius approach to identify that you're not going very proximal and you might not injure the ureteric orifices if you're opening the bladder neck a little wide?
Sorry, just one second. Can we just get a camera clean? So that's a very good question again. Now, when you do a retius sparing approach, your injury to the ureter is not at all near the bladder neck. It is completely when you are doing the vasa and the SV dissection. So if you're doing the vasa and the SV dissection, you're going very wide. That's where the ureter is closest to your dissection. Your bladder neck dissection in a retius sparing approach is completely onto the prostate. It is not onto the bladder. So because of that, you are very far away from the ureter or anywhere else. Now, obviously, if you don't have experience and you open the bladder quite away from the prostate, that's when you run the risk of having ureteric injury, but that is very, very rare. You wouldn't be doing that with, where's my?
I think there's some smoke inside. So Ashwin,
Yeah.
I have a very controversial question.
Yeah,
You are doing all this lovely work laterally, trying to save the bladder neck, have a small bladder neck.
yeah.
Now, I agree that having a small bladder neck makes life very easy when it comes to anastomosis.
Yeah,
Do you really believe having a small bladder neck adds to the continence?
absolutely. There is a randomized control trial done by Dix et al., which shows that sparing the bladder neck had much earlier. So again, see, all of these things are about what you want to find, because when you look at sort of 1-year outcomes, there is no difference if you do a proper operation. Whether you do it bladder neck sparing, non-bladder neck sparing, the single most important factor for your continence recovery is the length of the sphincter and how much of the sphincter you're able to preserve. So this is now anterior prostate done. So I didn't do the dissection there. I came onto the bladder, and I'm doing this to sweep tissue onto the prostate rather than onto the bladder, and I will join it here to the posterior plane.
Dr. Ashwin, one question.
Yes.
So do you think for somebody who is starting and learning how to do the bladder neck like this,
Yeah.
doing a posterior dissection initially would help?
Yes. Posterior dissection would help because you would then get to that plane a lot quicker.
Identifying the seminal vesicle and identifying those
Yes.
plane might be easier.
Yes, yes. You get to it a lot quicker. Here, because I did not have it and I wanted to show all the layers of dissection, I went a little bit slower. But you can get it a lot quicker if you have done the posterior dissection. Because literally, you go into the lateral space, you almost poke through, and then you're in. So you see how I am sticking onto the prostate here. It seems like he has a bit of a median lobe. Yeah, it could have a bit of a lobe poking in.
And between anterior and posterior, I was saying these are the exact cases where you would benefit from a completely anterior approach. There was bowel stuck on the posterior, so he didn't dissect the bowel.
There's no way you could have gone posterior. in this
So
guy.
for going posterior and doing the SV and a VAS first, we would have had to drop down all the bowel, which he completely skipped, and went anterior and dropped the bladder completely.
Sir, I hope that's not the Foley balloon, I hope.
This, it is not, no.
Okay.
So, Not many people do this, but so if you have a tough, hostile abdomen, you could always do this extraperitoneally. It is a very nice operation to do once you, it is nothing different, it is the same. Yes, Ashwin, there is a small median lobe on
Yeah.
the MR. We are just seeing the
Yeah.
MR.
You can see it on the MR. I can see it here intraoperatively.
Ashwin, your thoughts on extraperitoneal radical prostatectomy?
I think it's an amazing operation. It's slightly trickier to do than a standard because in my experience, I'm always using a 30-degree scope. I'm not using a 0-degree scope at all when I do it extraperitoneal because your angle of entry is here. It's not high up. It's somewhere here. So you need the 30-degree lens to get the 0-degree view that I had at the start.
So in your practice, how much, I mean, what are your indications? Let me
For
put it this way.
extraperitoneal?
Yeah.
So I would only do extraperitoneal if I feel that he's got, intra-abdominal adhesions away from the pelvis. Because the thing is, once you get intra-abdominal adhesions inside the pelvis, then whether you do it extraperitoneal or whether you're intraperitoneal, it doesn't matter. You sort of tend to get the same. So you were asking for where the Foley is. So let's have a bounce, and you will see that the Foley stops somewhere here.
Can we have a tug on the phone?
Because as I remember, when the tug was given, it was very symmetrical. It did not appear that we had a median lobe actually.
Yeah, he did not appear like that, but he does have it. You can see there.
Yes, yes.
But it's not that big, to be honest. It's very small.
So while it's very nice
See
to
there, you can see
Ashwin do this,
So you can see the
I
medial
would
lobe there.
say for the most of us, I think a simple opening the bladder, if at any point you're confused, just open the bladder anteriorly.
Yeah, you can. You can. It's all, you can do it, and I sort of sense that's where you were getting with your question of bladder neck sparing versus not. And certainly you can get a small bladder neck. You can spare the bladder neck without doing all of this. It's about having a technique that you can do even complex cases with.
Yes.
Because the thing is, with this sort of, you can't, if you go down directly, you cannot do median lobes. You just cannot. You have to, you end up opening the bladder. Whereas with this way, I can deal with median lobes this way. So this is just a bit of teaser that's coming actually. It's not even...
And still preserve the bladder neck. We can see it is very nicely.
Yeah, it's very nicely
Very
preserved.
nicely.
No, my comment was only for people like us, most of us who are just starting out, or when you feel lost, because I feel this is the area where most of the surgeons who are starting out feel lost.
Yeah, no, absolutely. I completely take your point. I know surgeons who will still not attempt to do it this way. They will still sort of go just down because that's what they're comfortable with. But that's fine. That's okay. There's nothing wrong with it. But it's about developing a technique that works for you.
Yeah.
I feel like in the beginning of your career, you can start doing the anterior, get used to it, get used to all the anatomies, understand the bladder neck properly, then probably switch over to whatever technique we...
So we've opened the bladder there, the urethra there. So I'll open it up. So balloon down and catheter back, please.
So we are actually appreciating the third arm usage of the traction on the median lobe to assist you in this.
Yeah. So let's get the balloon down and back, please. So you can see bladder, prostate, so cutting in between. And I will not cut anteriorly until I have finished the posterior bladder neck dissection, because that is where the bladder is currently tethered before I cut anteriorly.
So basically this is just a 360-degree dissection of the bladder neck.
Yes.
If you put your instrument from right to left, I think it would just cross over now.
Yeah, it would. But I don't want to do that yet. I'll just go down here. because he's got a median lobe. I don't want to go into the median lobe. So although most often than not, median lobes don't have cancer, and a lot of people will tell you it's okay to leave a little bit of the median lobe behind, it sort of leaves an irritating residual PSA that, you know, oncologists will jump at and say, what on earth have you done? So you can see here the various layers: vas, fat, posterior detrusor slips, which I'm going to incise now. And there is even evidence that the more of the detrusor slips you spare, and that is why I'm lifting that up, because if I don't lift this up and if I push down, then I'll be cutting the posterior detrusor slips here, which then makes my Rocco a little bit more difficult to do. So I want to incise the detrusor slips up here so that I have enough of it to do the Rocco.
Can we have a camera clean if that's okay?
Yeah, we can. Absolutely.
So I've noticed you don't use the catheter to kind of tent the prostate up while doing the posterior dissection, which is something I seem to see quite popularly being done in a lot of...
You can if you want to. Can I have a camera clean, please? You can if you want to. I mean, again, this is a very sort of medium-sized, small prostate. You don't really need too much of that. And what the anterior tenting does is it pulls the anterior prostate. It doesn't pull the posterior prostate. And because my bladder neck dissection is more sort of posterior to the bladder neck, I don't gain much by an anterior traction. I gain much more from a posterior traction of the median lobe or posterior prostate.
Also,
So
whenever there is a median lobe, by just pulling a catheter above doesn't really help.
Yeah.
We
Yes.
tend to take sutures and then pull when we are using only.
But I see Rahul's point here. If
So
there is no
for-
median lobe and you have a catheter pulled up, so my fellow surgeon does this. He puts a Keith needle, takes through the eye, and his idea is that it frees up your third arm, because right now
You
your
can.
third arm is just
You
lifting
can.
up.
Again, like I said, if in a tricky case, you can. So now we're doing the vas and SU dissection. I don't go from side to side. What I tend to do is I go down the midline, and my dissection is first in this avascular plane, and then I will separate out the right and the left vas.
Where is the camera person? It is also important while we are discussing this to make sure that your assistant is, I just noticed Praveen is sitting very comfortably here. For you to have a good case, I think your bedside assistant has to be very comfortable.
Absolutely. And
if-
very experienced.
If the camera can be zoomed on to Praveen just to show.
So this is
He-
what I'm doing now, is peeling the denombiliers off the medial side of the vas on the left side. And what I will do is I will take it all the way to the SV. I will not clip the vas until I see the tip of the SV. So using my bipolar, I fan it open, and I can see the tip of the SV here. So then I know that I need to take the vas somewhere here.
One second, Ashwin, they've just switched the view. So can you zoom out, please? You can see he's sat very close to the bed. He's almost stuck to the patient. His shoulders are not raised high up. The camera is at his eye level. It is very important that you pay attention to this before sitting on the console, because once you're sitting there, I think we can zoom out, that's it. Once you're sitting there, you are kind of unaware how comfortable your assistant is. And you can go back there, thank you. Even the screen is at his eye level.
The placement of the assistant port, it goes a long way in making the surgery comfortable. Because if you don't place it properly, you would be peeking under the arms a lot of times to just get it in, reach the right place inside to suck. So all of this, as Ashwin said, you need a very experienced camera person to, a bedside assistant to make it very smooth.
Right, so we'll go back to the vas and the SV dissection. So left vas, denombiliers freed from the butt of the SV. The pedicle of the SV will be here, and this is where I will take the vas when I get to it. but I will do the same on the right side so you can see what I did. I'm holding the vas very close to the prostate, lifting it up. Very important to angle your wrist of your prograsp up so that your instruments don't clash. And then this is your denombiliers here. So we'll peel the denombiliers off. So what I want to do is I want to get to the SV on the right side, which is there. So your Maryland is very helpful in these sort of dissections.
What I have noticed here is the Maryland that is moving. The movement that we can notice here, how it fans out when he dissects, I
Yes.
think that is the learning point here.
So this is now the posterior dissection here that we'll do later on after I take the vas in the SV. So I'll probably start from the right. So what I've done, so the next step is what's called pedicalization of the SV, which is basically, you know where the vas is. I still haven't clipped the vas. I know this is the seminal vesicle, and I am taking the pedicle from lateral to the vas, sweeping the pedicle off the vas, and get to where I initiated. So this is the vas SV pedicle, and I'll just cut through the SV. I don't really clip the SV. It doesn't do anything. What is important is to control the bleeders. So you can see, even though I'm going to be doing nerve sparing, I don't mind using monopolar diathermy at this level because this is very far away from the neurovascular bundle. Right, so now the vas is off the SV. So once I get the vas off the SV, I'll hold the tip of the vas, lift that up. Again, angle of the prograsp is up here. And then I can then visualize the SV here. And you can see the pedicle of the SV here. You've got some slightly larger vessels. So I'll try and separate these out and take them individually rather than taking them in en masse because that doesn't help. So again, trying to isolate the SV there. So I can take this little bit, bipolar again. Don't worry, I don't use any clips. If I need clips, I'll ask. Thank you for letting me know. So then this is again the pedicle of the SV again. Single blade, close.
Very meticulous.
So this is full control of the pedicle. And you will see I like fanning out both my scissors and my Maryland. That allows me to get in a plane and do blunt dissection without getting into bleeding. So once I have done the sort of the medial bit of the pedicle, I can hold the SV up, and then I can get to the rest of the pedicle. And this is why you need to take the vas at the level of the butt of the SV. If you take the vas too early, then getting to this bit becomes very difficult.
Yeah, you just end up chasing the tip
Posteriorly,
of the SV.
absolutely. So again, you're making the vessel small enough for control, and then push the SV up rather than down because we're doing our dissection here. If you push down and operate, then you'll run into bleeding, which you cannot control. And we can see if I need to take this lateral bit here, which I think I need to because the SV is quite big.
So just a time-saving trick. He used his right hand, the scissors, to hold up and then changed his fourth arm. And
Yes.
So a lot of the times we tend to just drop it and then pick it back
Absolutely,
up.
I see. You're absolutely right. So that's a very important point in terms of transfer of instruments. So when I'm switching between the fourth arm and this arm, I don't hold this and then switch. Lift up, and then if I need to move, and then I can always switch. So this is now denombiliers here. Now because I'm going to get interfascial posteriorly, I won't go too wide. I'll stay here. And that will get with the posterior dissection. Okay. So that's the right SV done.
Do you ever leave behind the tips of the seminal vesicle, as they say, for cases where very necessary to preserve the nerves? Have you ever felt that is necessary?
So what we have found, preserve in prostates, oddly enough, not so when we do, I do a lot of organ sparing cystectomies where I leave the whole vas and SV behind and the capsule of the prostate behind, and in those cases it sort of seems to work okay. But if you just leave only the tip and nothing else, they get a lot of pain during orgasm, and that's sort of well documented. We've had patients who we have had to go back and take the residual SV out because of the pain. And so, again, I'm not taking the SV until I see the butt of the vas, until I see the butt of the SV, and I'll just monopolar through it. You don't need to do much here. So he's obviously not empty, the seminal vesicles. It sort of tells a little bit about his, probably his priorities in terms of erectile function. So when I know that I'm in an avascular plane, I can go in, fan whichever instrument it is, either Maryland or scissors, and then open it up. So this is now coming to the denumbilier, so I will not incise it too much there. So this is where I'll show a bit of transfer. So don't think I've done the tip yet, so I'll still stick up with this.
I think the role of assistant here we need to appreciate, where he is retracting the bladder neck there.
Absolutely.
A little bit back, and all the suction that he's doing.
The credit goes to Dr. Tushar for training him so well.
And for him as well to learn. You know,
Yes,
it's very difficult to learn, isn't it?
It's also very popular on Instagram.
I think
more popular than
we
Tushar.
have to
But not as more popular than you, Rahul. So that's a bit of a next level for him to get to.
I think Praveen has taught Tushar a few things as well, right? I saw is there a position named after you, Praveen?
Is it the supine position?
Yeah, something for glaucoma.
Yeah.
Isn't
So we do that quite a bit. Where I mean, I know Tushar in the morning was saying you have to get the X between the legs, but in patients with glaucoma or very high BMI who've got issues with breathing, we tend to side dock, break the table, and keep them as supine as possible. So this is not just a wide hemolock. That's one of the reasons why I don't like clipping, because it tends to be very blind. Whereas with this, I know where I'm controlling the vessels.
Ashwin, is this going to be a clipless procedure?
We'll try to make it clipless. Because, I mean, if you're doing a wide excision, then you have to use some clips because you're going quite wide. But because I'm not doing a wide excision, I can try and see how I get away with it. I never aim to do one or the other. What I tend to do is I tend to have my team not open the clip, but sort of have it close by. So if you could come in with a grasper, beautiful. And then this is pretty much lifting up like a Mickey Mouse, ears. So at the base of the SV. So that is very important. So you see how he did that effortlessly because he knows very well where he needs to get to. So at this stage, I'm going to switch over to a 30 up so that I can get into a better plane. So you can see the layers now. So denumbilius fascia, fat. This is extrafascial. So what I can do is pull this towards me, and then you can see I have already inadvertently made an incision and opened the interfascial plane there. Now when I get to that, what I'm going to do is I'm going to switch my traction. So I'm going to twist my Maryland. Because I've got a curved Maryland, I'm going to twist it, lift that up, and then push this down with my scissors, and then he will get in, absolutely. So he doesn't have much of a posterior fascia. You can still see fat underneath. But in the midline, I am going to go to the apex in the interfascial plane. So this is what I spoke about, the ventral venous complex. I can see some veins starting here. I don't know if you can appreciate
We
it on
can,
the
we
camera?
can, yes.
So just get down here with the sucker, that's perfect. So you can see some veins starting here. So that's the apex of the prostate. So once I get to the apex of the prostate, then I start sweeping laterally to get into the nerve-sparing plane. Now what I tend to do on the right side, I am predominantly doing the dissection with my Maryland. And for the nerve spare, you always start mid-gland to apex. And that's where it's the most avascular. So you start mid-gland to apex and follow that up all the way.
When you keep going into this plane, at some point you'll come across the prostatic artery.
Yes. So you can see the line of the fascia there.
I just want to re-emphasize the Maryland there, that he's lifting the prostate, that this step is so important to get into a right plane and to give a little bit of a traction that we would require.
But also gently. He's doing it very gently because
yeah.
the
We should
Maryland
not
is
be
a
poking
very
inside
sharp
and- yes.
instrument.
Yeah.
I see not a lot of surgeons preferring to use a Maryland. Most of them because of how sharp it is.
So in terms of layers, intrafascial, interfascial, extrafascial. So if I want to continue intrafascial, I'll see how he goes. He's got significant disease on the right side. So if I feel that things are not peeling off, I'm not going to hesitate to go interfascial on the right side.
Seems to be a little stuck.
Nah, it's all right. But like I said, so what you have is you've got artery, vein, and then you've got nerve. So even if you are leaving behind a vein of, so you can see I'm leaving behind some vessels there, still intrafascial if you ask me. And I like the Maryland here because I can hook, close, buzz. Easy way to control. You don't need clips. And then I can open. And you see how it opens up the space? The Maryland is very good at doing it on the right side. You can't do the same with the Maryland on the left. You need to use the scissors on the left. But just sort of spreading, getting the tissue away. It is coming off, so I don't think he's got very bad disease.
Beautifully peeling off. Just to remind the audience that the disease, most of the cores are positive in the right side, and only one core is positive on the left side.
Yeah.
3
so
plus 4.
what I tend to do when they've got low-grade cancer, like, well, intermediate risk cancer, but I call it low-grade because it's not primary pattern 4, I tend to see how the layers come off. If the layers are coming off nicely like this, then I don't mind doing an intrafascial. If the layers are not quite as good, then I will switch to an interfascial. But it's been okay so far here. So once I get to that point, I'll take this. Thank you. Yeah, you can let go of that. Thank you very much.
Dr. Ashwin, can you also show us a trick where you curve towards the angle of the prostate?
Yes.
So when we go from the posterior,
Yeah,
so this is the place where we should not be going
yes.
straight.
So if you go like this, then there is no nerve spare.
Yeah.
So you have to be going up here. So what I'm doing is going up here. So I will use my scissors as traction laterally, Maryland through that.
So clips versus just bipolar.
Yes.
Your opinions on that?
So I think we spoke very briefly about it in the morning. There are a couple of things. Obviously, it depends on the experience of your assistant putting the clips. But also what happens is with clips, we have had patients occasionally pass clips. And that can be quite painful. So I tend to, as much as possible, not put any clips.
So I was generally not very afraid of clips, but I have a patient currently who's developed a rectovesico-urethral fistula because of a migrated clip.
Wow. I mean, it really depends on what sort of clips they are, but they can be quite horrible sometimes. So
Especially if you're doing radiotherapy afterwards.
yeah. So the reason I switched from going completely medial to lateral to go lateral to medial is because you have perforators beyond this point. So what I want to do is I want to be able to control. So you can see one perforator here going into the prostate. So I'll take that. And you don't really need clips for that.
Sir, everybody is really appreciating the beautiful nerve sparing that you're doing, sir.
Thank you.
Just one question that the audience here has, that the earlier teaching, traditional teaching, was to do a very athermal dissection here
Yes.
for the nerve sparing.
Yes.
And now that we are seeing you use bipolar,
Yes.
what is your experience and what is your actual outcome, so that you can enlighten us about the erectile function following this particular technique that you're using?
Yeah. So that's a very good question. So athermal dissection refers to the monopolar, not to the bipolar. So you can use bipolar. It has a very minimal spread. And I mean, if you ask the colorectal surgeons, they will still use monopolar when they do their posterior dissections, albeit they're not this close to the prostate. But they will sort of still do thermal dissection. Now, this is still athermal dissection. Now, if I was going through this with monopolar, then yes, that's thermal dissection, but this is still athermal dissection. So here, he's got a bit of, the planes are not quite as clear, but we can try and see how we get through that.
Ashish, to answer your question, there is a surgeon in Martini Clinic, I'm forgetting his name now.
Alex Haase.
He
Is it
has
Haase or
a
is it the other
series
guy?
of about, I would say now 500 cases where he has only used bipolar.
Yeah.
And he has about, I would say 3 or 5 years of follow-up of these patients. So big number, good follow-up.
Yeah.
And that shows no difference in terms of erectile function, continence, anything.
No, absolutely. I mean, we have a series of around 3,000 patients where we have done athermal dissection like this with the bipolar. Obviously, the practice in the UK is very different from the practice in Germany, where they probably will take anyone's prostate out, whereas in the United Kingdom, we have a quality metric, which is the number of prostates we take out for Gleason 6 or low volume Gleason 4. If it's more than 10%, then you're actually told off. So we wouldn't operate on patients where, the type of patients are very different. But yes, we have, I mean, the retro-sparing cases are completely athermal with bipolar control without clips, and so are the anterior prostates now. Now, on the right side, the positioning of the arms are slightly different. So I turn my scissors like this to curve towards the prostate.
Ashwin, could you zoom out and show them what your fourth arm is doing? Yeah.
So my fourth arm is lifting the left SV up in the midline. So not left, not right, up in the midline. And then what I do with this Maryland is I go like this and pull away. So what I'm doing is I'm going like this and pull away. And then the scissors will then find the plane quite easily.
For everyone, just note he's being so gentle. Obviously, yes, this is a good case, but not all cases.
What makes such cases possible in higher volumes in the NHS, I believe, is the presence of a very strong screening program.
Yeah.
So NHS promotes screening a lot. We had, I'm sure, Ashwin, you're aware of the Man Van, Masood's project.
Man in the Van. But actually, there's been a lot of direction against screening just because they want to run the Transform trial to try and see how to screen them. But I think eventually we will get to a point where we're probably screening them with PSA, but also with MRI, even at the sort of the primary care setting. So our setup is slightly different in that they will go primary care to have their PSA, and if it's elevated, then they're referred on to the hospital for MRI. So this is now the prostate pedicle that I'm taking.
So,
you can see.
Ashwin, could you please
Also
tell us
explain about the high
for the
release.
benefit of the audience, about high release.
High release, mid release, and low
mid-release.
release.
Okay, so I'm going to do high release on both of these.
No, but
So
just
th-
if
what
you
are
could
the
pinch and
difference?
show
Yeah.
what the difference would be between all these three.
Okay, I will do that. So at the moment, I'm just doing a posterior dissection. So once I get lateral, I can do that again. So this is not quite intrafascial yet because I can see veins there.
So this is a retrograde nerve release
Yes.
in essence.
Yes, so medial to lateral retrograde nerve release, absolutely.
I also do the same thing, and I think when we go from antegrade, we end up sometimes clipping. We can't see where the clips are going to. I still use clips. So, you know, even after doing a good nerve spare, sometimes you end up clipping nerves
Yeah.
going from the anterior way. So
Yeah.
I think this is a nice way to do this.
And I think if you want to do ratio sparing after this, I think this is a good place to start, because if you can do your nerve spare medial to lateral, so that's now the intrafascial plane. If you want to do it medial to lateral, then that's your first step of doing it ratios.
Just for the audience, I'd like to highlight that when we are in the intrafacial plane, we should not be seeing any vessels over. So when we are
Intrafascial,
seeing
yes.
the vessels, that means we are not intrafacial.
Yes. Yes, absolutely. So that's why I sort of moved back to the base. You can see other bigger vessels, prostate vessels here.
So if any four of you can say, so correct me if I'm wrong. So in the intrafascial plane,
Yeah.
we would technically have the least amount of bleeding.
You would what, sorry?
We would have the least amount of bleeding in the intrafascial plane.
Yes, you have really, you definitely have reduced. If you're having to clip when you're in the intrafascial plane, you're not in the interfascial plane. You're in the interfascial plane. In the intrafascial plane, the only thing you clip are perforators. You don't clip sort of vessels. So what I'm doing now, because I've sort of not been able to peel it off that way, I'm going to put the back of the bipolar against the neurovascular bundle rather than the front of it, because the front, like you alluded to, is not very friendly. It's a little bit more stuck on this side for some reason, although he's got lesser disease. And then the prostate, the scissors will, once I put the tip of the Maryland into the plane, scissors will pull the prostate away to show you where the base of the prostate is.
See, the prostate, everyone can appreciate it, looks like an eggshell, like an unbroken eggshell.
Yeah.
If you start seeing something like a honeycomb appearance, or if it starts becoming a little brown or beige, then you've cut into the prostate.
Yes. So honeycomb means you're in the veins. And so this is another perforator going in here. And this you can only visualize with a 30-degree up rather than a 0-degree lens necessarily. Do all of you use a 30-degree up for nerve sparing, or?
Yeah, I do the same what you're doing.
I also do the same, yeah.
30 for the whole case.
Okay. So this seems to be going into the...
Ashish, what do you use? 30-0?
As Dr. Ashwin rightly said, if I'm doing a good nerve sparing, then 30 is, I think, mandatory, because it helps you see the entire contour of the gland. But if you're doing an extrafacial dissection, even in Redges, I have completed the excision part with 0 degrees.
Yeah, absolutely right. I mean, if I'm doing a wide excision, I wouldn't bother with a 30-degree lens. And we have started doing the anastomosis of the retius even with the 0 as well. So, you know, you can do the whole case with a 0 if you're not sparing any nerves, which in our sort of practice, because we operate more on high-risk disease, we see very few patients who will. So this is sort of the experience with retius, what it gives you. So you see how the fascia is now, this is the anterior prostate now. So you were asking about high release. So this is now going onto the anterior prostate, and you've got some perforators again going into the prostate there, which we will control because you don't want it to bleed. I've already had my share of bleeding with the external vein.
Are you doing neurosafe for patients where you're doing bilateral intrafascial nerve, intrafascial dissection or no?
Not a standard. So we don't do neurosafe as standard in the NHS.
Do you do it, Dr. Madhav? Yeah.
So we
Yeah.
are doing it
We
for
are doing it,
everybody
yeah.
who were doing a
Any nerve sparing goes to frozen section.
Frozen
So
section.
for us,
So the only reason I don't do it is because if I feel that the patient's better off with an interfascial, then I would rather do that. So once I have gone till here, so this is posterior prostate. If I just do the nerve spare here, take this off, that's a low release. High release, I will follow this whole thing anteriorly, and I can afford to do that because he doesn't have any anterior disease. Now, just have a look at my prograsp. I'll go to a 30 down just to show you what it's doing. The wrist is down, holding the SV, pulling back. The sucker will come above this, okay? So this is not going to be in your face. It's going to be below the sucker. Or can I have a quick camera clean, please? Yeah.
what do you do, Dr. Ashish? Do you do neurosafe regularly?
No, not really. Actually, we are trying to buy that confocal microscopy for these cases, but actually, my personal opinion is that Indian cases are not very favorable for very aggressive nerve sparing sometimes.
Yes,
So,
yes,
may
agreed.
I
not be
agree.
very-
The amount
Agreed.
of prostatitis we get is a lot.
But rest aside, Dr. Ashwin, you have done a wonderful nerve sparing on the right, but even a better job on the left side, which was really stuck, and still you have managed to preserve the entire thing.
And if you
all
look
of-
at it, Ashish,
yeah.
he's
Sorry,
preserved the
can
entire tissue
another clean, please?
in front of the prostate. So, so more or less, you have kind of created a hood.
Yeah,
and
so I
you-
will create a hood. So I'll show you the hood technique because he doesn't have anterior disease.
So everybody is really appreciating the nerve sparing and the meticulous dissection, sir.
And we finally got to see what Tushar always keeps on talking about in meetings, the UCLH way of robotic prostates. So it's actually great. I must thank Tushar when I meet him.
I'll thank him as well. You're all singing praises to me. Normally, I'm not even operating in theater. I'm just sitting in the coffee room doing something else. So now I'm getting a bit of a FOMO. I'm going to go back home and start operating again. All the fellows are going to hate me. Right. So this is part of the ratio sparing approach where I will push the prostate away from the neurovascular bundle rather than the other way around.
For the audience, this pushing the prostate away is so important to create a plane and develop and push away the nerves.
There's also that you prevent traction injuries if you do it this way. So if I'm pushing towards the nerves like this, then it'll give you a traction injury, whereas pushing the prostate away from the nerve prevents traction injury. Right. So now I can use monopolar here because I'm well away from the neurovascular bundle. This is now anterior prostate. This is where I have to be a little bit careful that I don't just go across like this. Then it'll go through the base of the prostate. So what I'm doing is incising and then pushing the prostate away again. Probably just finish up the posterior bit a little bit and then I can go to the apex. Right.
Dr. Ashwin, do you develop a 3D of a prostate?
So
At
we
your
have tried
center?
doing that. So we have tried doing 3D printed models. We've tried doing augmented reality, but you know, at the end of the day, if you know where you are, then that's the best thing you can offer the patient. The models, the visualization are very good for sort of training, but not, I wouldn't say, are excellent for actual surgery. They're not essential for surgery. Not that you know they're not good, but they're not essential for surgery.
So for the audience, if you are aware, there's a terminology called the levels of nerve sparing. I believe in the UK it is just either nerve spare, full nerve spare, incremental nerve spare, or wide excision. If you follow Dr. Ash Tiwari's
Grade 1 to 5.
classification 1. So this would be a grade 1 because he is inside the veins. If he was cutting through the veins, you can see the veins on the left corner there. So this is a level 1 nerve spare. If he would have cut through,
So this is the
veins, it
ventral
would have been
venous
through.
complex that I told you about. So this means that you're well to the apex of the prostate. You don't need to go beyond this. You can see the veins coming here. You don't need to dissect anymore. I'll switch back to a 30 down now to do the rest of the apex. Am I going too fast or is this an okay speed? You want me to slow down?
This is fine, sir.
This is fine? Okay. Right, so now the whole sort of posterior lateral is done. Now before I do the apex, I want to do this. I want to find the urethra between the DVC and, so at this point I don't go too close because the apex does not have a capsule. So I don't want to go sub-DVC. I will try and leave a little bit of tissue at the apex because it doesn't have a capsule.
I think apex is the place where we need to be more careful during nerve sparing. All
Yeah.
the nerves will converge there, and all our effort of sparing nerves will go in vain if we just cut it there.
Absolutely. But equally, it's the most common place for posterior margins.
Yes.
So if you go too close to the apex, because the apex again has no capsule, and I don't know how they do the path here, but in our centers, they take the apex as separate slabs. So the first slab they take, they call the apex. And sometimes, if they don't get enough tissue at that, they'll take the next one. And a lot of the times, we'll tell them, well, you've lost the first apex, but you still call it a posterior margin. Anyway, that's a sort of a discussion we have with our pathologists, but ever since we've got a very good pathologist actually from Delhi, Ayman Haider, we've sort of found it preferential for us. Anyway, so that's done till the apex there. Now, the reason I leave a bit of bladder, very much like partial nephrectomy, is you have something to hold on to. So now, if you dissect here, he's going to get incontinent. So what I'm going to do is I'm going to dissect here. So this is apex of the prostate there, but I can spare all of this tissue. I don't need to take it. And this will be where the DVC starts. So we don't need to necessarily raise the pressure at the start, but if it bleeds a lot, then we might.
Would you say again here, the more proximal you cut, the lesser it bleeds?
Absolutely, because the DVC fans out into this here, which we have already controlled. So this is what I was talking about, the off spin and the leg spin for people who play cricket, which I'm sure most of you do. And it's also very, very important, if you see what I'm doing with my Maryland, is pushing the prostate back like this. And it's only at the apex that I sweep tissue away from the prostate. It's the only place where I sweep tissue initially away from the prostate. And then when I go anteriorly, I will come back again to start sweeping tissues towards the prostate. So that's urethra there. Now I'll do the same on the left side. Again, I've left a bit of bladder tissue on prostate so I can do it. And now you see, I'm not going there, I'm going here. I'm joining these two. And this is the tissue you spare when you do Retzius. This is actually muscle. This is a sort of this is detrusor fibers, anterior detrusor fibers that are continuing from the bladder to the external sphincter. So, you know, obviously sparing is better than not sparing, but at least reconstructing at the end is better than not doing anything at all. Right, so now both dissections are done. I will lift this up, see where the prostate is, cut, and I want to open the DVC under the DVC. So not through the DVC, but under the DVC, so I know I'm in the right plane. Again, because the apex does not have So people are asking me where all you could do DVC sutures. So you could either do a DVC suture before you get to this, or you could do a DVC suture after you have finished the apical dissection. So now I'm gonna, once I release the prostate and get to the urethra, I don't want to push away because that is where I'm gonna get to the sphincter.
Do you want us to increase the pressure, sir?
Not at the moment, it seems okay. If you think it's bleeding a lot, go ahead, but I'm fine with this. When I see my videos, I always sort of wonder why do I tolerate so much bleeding, but it seems all right. If you cannot see, then let me know and I'll raise the pressure.
So sometimes in the apex,
Yeah.
the prostate tends to go posteriorly in the
Absolutely,
apex.
and this
so
is
what is your
exact.
trick on that, sir?
So this is why I do the posterolateral dissection first to know exactly where the urethra is. So I know urethra is here. So then this is even before I've cut through the whole DVC, right? So I'm cutting all of this here. This is all getting to the urethra. And then I can leave that there. And I can do the same on this side. Sorry, let me get under you. That's good. And then you can get above me.
Ashwin, could you please zoom back and show them your fourth arm again? Because see the angle at which his fourth arm is. It is not straight, it is making an L. Unless you do that, your assistant will not be able to come in and help you.
Again, I can see the prostate arching like this. So I will cut.
Gone like this,
Now it is quite
like this.
it is quite usual to cut very close to the prostate, and when you get positive margins, what I've learned is if you just go a millimeter beyond, then you're okay. So I will always go a millimeter beyond what I think the apex is.
For the audience, the sweeping movement Dr. Ashwin did just now with the scissors is very important, just to understand where the probable apex of the prostate
Yes.
would be. Now.
Absolutely. So what I'll do is I'll sweep with the Maryland, see the posterior bit, and then I'm not cutting here, I'm cutting here because I want to leave a bit of tissue. This is what is called the collar technique, where you're leaving a little bit of tissue and then pulling back to pick out the intraprostatic urethra.
Also, I think once this step is done, if you really wanted to, I do it sometimes, you could invert this prostate upside down.
Yes.
You could really have the posterior thing come up and cut your, sometimes you'll not be able to see, especially when what Kinju was saying, if you have a C-shaped prostate,
Yeah.
you can rotate it completely upside down and cut the posterior half from that way.
So I don't think I need to spare more than this, so I can go through the urethra here.
मैं वही पूछ रहा था, मैं वही पूछ रहा था.
So cut a little bit in the midline, back half to the back.
So, Dr. Ashwin, would you first like to suture what part of the DVC, some part that you have opened, or do you routinely divide the urethra and then with one instrument exchange you do the entire reconstructive part?
It really depends on how much bleeding there is.
Okay.
Here it's not actually bleeding that much, I would like to think, but obviously I might be wrong. You can look at the...
No, it's very acceptable. Everything is very clearly visible.
Yeah.
So we are on the same page.
So the reason I prefer to suture at the end is because I like to take the DVC in multiple layers. And what I find is when I suture and then I cut, I find that, oh, there's a little bit more DVC. So I always, it's okay, I don't think I need the irrigation.
No,
Is there any reason, Ashwin, why you don't raise the pressure while you are cutting the DVC so that there's no bleeding, and then you
That
do
looks like a prostate, is
Yeah,
it?
I think I'll take a little bit more here. Perhaps a little bit of posterior prostate there.
No, so Rahul, I think that is just the way we've been taught, that if you increase the pressure, it's going to go down. But no, like I said,
momentarily,
but
just
it really won't. I think if you really want to stop the DVC bleed, you
see, sometimes you have a very robust DVC which does not respond even if you raise the
Yeah.
pressure.
Yeah. Exactly. So I leave it very fluid. I'm not fussed. I'll
Okay.
take it as the case goes.
But you could switch off your Flowtron compression pumps. That will reduce some amount of bleeding.
But also, if you look at the physiology, right, what is the pressure within the pelvic veins? It's 0 to 5 millimeters of mercury. So, needle holder in my first arm as well, please, number 1.
Dr. Ashwin, we are amazed by your nerve sparing surgery. It was
you.
beautiful.
Well, hopefully he benefits from it. Can I have a needle holder number 1 as well, please? Thank you, Tushar. So needle holder in this, please. Number 1. Perfect, thank you. And then can I have a bit of suction at the bottom there? Yeah, that's it. So I'm going to do a 30 up for the DVC. Can I have the catheter in, please?
Do you guys have good vision there? Do you need a camera clean, Ashish?
So my DVC closure is quite wide. It's not sort of just at the DVC. So what I tend to do is I tend to start as wide as necessary. Usually it's like a 3 o'clock to 9 o'clock closure, and it's in multiple layers. And this is one of the reasons why I prefer to do it after getting the prostate out, because with the prostate in, you cannot do this. And Tushar, I'll get Phil Block to come and get the sutures for you. You will love
Phil
it.
Block. Phil Block.
Phil Block, you will love those sutures.
That's a very, very nice suture. It's the
Yeah.
it's
A suit, yes.
it's
Yes.
now available in India.
Is it?
Yeah.
Okay.
For the last year. Phil Block. Phil
Yeah, it's FILBLOC, I
Phil
think.
Block.
Phil Block.
It has
Yeah,
a
it has a
bead.
button. So it has a button that's made of the same material as a suture. And the advantage is I don't have to go through the loops. It just makes it a bit quicker.
And also they have a 5x, is it a 5x8 needle, right?
5/8 needle. No, you've got a 5/8 even with the V-lock.
Not in India, you don't.
You don't?
No,
All right, okay.
we don't. We get a monocryl, so for what we use for open prostatectomy, we get a 5x8, but none of the other companies have that in India,
Right, okay.
other
Which
than
is
Phil Block.
interesting. So again,
This is not.
the other advantage of the fill block
It's,
is you see how this barb
normal,
suture, they are cut in a spiral, the V-lock. Now what that means is when you cut the suture in a spiral, the bit of the suture that actually provides the, I don't want any perineal pressure, please, that's fine, thank you. The bit of the thread that provides the strength is actually a third of the stitch. It's not majority of the stitch. Whereas in the fill block, they etch it only on one side. So because of that, the 2/3 of the suture provides strength. And so they are actually much stronger sutures. And that's one of the other reasons why I prefer to do that. I've just locked this here because I have used V-lock and I don't trust it. So I always lock it after a couple. Say again? Are they in theater?
What suture do you use back home?
Fill block.
Okay.
So we developed the fill block with Asut in their company from Rome. Lovely facility.
I stole a few of them when I was coming back.
Did
They're still lying on my desk.
In
It's got a button at its end.
Yes.
It's beautiful. It just fits right into place, and
So in India it is available, but if you want to try something other than
So I'm
V-lock,
willing to sell them at a premium if somebody offers me money.
you also have the starter fix. I used to use the V-lock, but I personally find it very harsh,
Yeah.
the barbs.
They
So
are.
I have since the last maybe couple of years moved to a PDS starter fix. And
Yeah.
I find that so smooth, it glides, hardly ever cuts through. So that's, it's similarly priced, not much of a difference. Starter fix. Starter fix, but
The Stratafix is too,
on a PDS.
yeah, but
material.
the problem with the Stratafix is it's too weak. It's not a strong suture.
We use Stratafix for partials. Partial
Okay.
nephrectomies.
No, it is. John.
Okay, are you okay with the vision or do you want to clean? So we'll start the Rocco and the anastomosis now.
Can we request a camera clean?
Yeah,
before we
sure,
do?
okay. You can get a
Dr.
camera
Ashwin,
clean.
I have one question.
Yeah,
When you were dissecting urethra anteriorly, you were
Yeah.
using cautery. Is it all right?
yep, absolutely. So you can use cautery, and it sometimes is better to use cautery because what happens when you spare the membranous urethra is you will see that it inverts. And when it inverts, if you don't catch the mucosa, then it bleeds. And we have had patients who've had hematuria from the time they're on table, and you go in and you scope on table, they're bleeding from the urethral edge.
But I saw you didn't. You use the energy only on the anterior
only on the anterior and not on
aspect,
the
not on the
posterior.
posterior.
Yeah, I didn't need to. I mean, if I see vessels, I will. The periurethral vessels can be quite troublesome if they bleed, and until you do the anastomosis, they'll continue bleeding. So that's one of the other reasons why I prefer. So let's have the next suture, please. So this is the longer suture, isn't it? Yeah, so this is the longer suture, so not the 15 centimeters or 17 centimeters, like the first one. So what we're doing now, we'll see the various layers that you're going to take. So just suck here, please. So all of this bleeding will stop. So this is now the posterior anomalies. So that's number one. And the bladder neck is, you see, completely inverted. This is the posterior detrusor, layer 2. And because this is the V-lock, I will go through. So this is a modified V-lock. Right. You've got a very enterprising assistant. Yeah, no, absolutely. I'm happy you have done that to make my life easier. So this is now urethra. You've got an open vein here, so I'll just take that.
I think this is more important because when we take Roku stitch here and when we are doing bilateral nerve sparing, it's very important not to go laterally
Yes.
and take the sutures here.
And take all the nerves.
Yeah, because the nerves would get entrapped.
Is he okay? So I'll go underneath as well. So if you could suck there. Thank you.
So this is one of the issues with the 30 camera. Sometimes, especially when you've done a nice hood, you will feel a little claustrophobic, especially during the anastomosis.
Yeah,
This is where 0 is nicer.
it is. It is. It can be. But let's see. So, again, we're taking the non-Méliès. We're taking posterior. And what I like doing at this point is
Dr. Ashwin,
Yeah.
when you tighten this eventually,
Yeah.
your Rocos, I would appreciate if you tell them the order in which to pull the sutures.
yeah, absolutely. That is also very, very important.
I think when you are pulling, you have to make sure the traction is not at the point where it enters the urethra, because the periurethral tissue, because that's where you tend to cut through.
Yeah.
So you have to kind of place your left hand, create sort of a open forceps thing to release, to dissipate the pressure while you pull.
Yeah. Absolutely.
And what are your thoughts about a two-layer posterior recon, which some people do, a lot of people do?
Yeah, he's just doing more and more suturing. I don't know if
Yeah.
it's necessary.
I also do
A
a
lot of people say it prevents leaks at the vesicourethral anastomotic site.
See,
if
as
you
long
do-
as you're happy. So
Yeah,
this is where
yeah.
I'm starting to pull up. As long as you're happy with how you're.
So you see how he's
It's
pulling
put-
it up. He's placing his.
My second
his-
arm
yeah.
blocks, the other arm pulls.
pulling it up, and he started
And
one away
with the
from
second.
He's
the
not
first-
pulling at the
First.
place where it goes inside the periurethral tissue, because that's where it cuts through. And you hold the first one tight, keep the tension low while you pull the next one.
So Rahul, you were talking about 2 layers and 3 layers. So
Yeah.
I do a 2 layer or maybe a 3 layer. The reason I like it is it just the posterior plate is almost done twice. So I am more afraid of a posterior leak than of an anterior leak.
I
So-
do it because I've seen it being done that way for most of my training, and also I think it looks better.
So yeah,
Are you
I do
asking me
almost
to do
a
2
3 layer.
layers?
After a 2 layer ROCO, I incorporate the bladder neck and the urethra as well. But that is just out of fear because I had posterior leaks.
Exactly.
So before I tighten that, I'll go back to tightening this again.
Fortunately, only 2 or 3 have had
Yeah.
a leak.
So that's stuck like
2 have
that. That's
become
good.
okay. One
Very nice.
wasn't continent for them.
So that's the Rocco done. You could put one more U if you want, but then because I've done a bilateral nerve spur, I'll prefer not to do that. So bladder neck.
Also here the mucosa to mucosa anastomosis is imperative.
Yes. Right, let's have the catheter in, please. So what I catheter in, give it to me. Yeah. So what I tend to do is slightly different. What you saw what Tushar did, is the first one I put with the catheter in, and then the rest of them I will pull on the sutures to make sure I'm getting good bites of urethra. So that's the first one, which is sort of 5 o'clock. And I don't pull it through all the way. I leave it as is for now. So I leave it a little loose, and then I pull these two. So then in doing so, you see that I don't really need to then chase a urethra that's sort of going away from me. So now these two, catheter back.
This trick of pulling the suture is important. where
Yeah.
we can understand where our needle would exactly go.
Yeah.
And we would also know, we would also get some space. If you pull the sutures and if you pull it a little bit down, we'll get
Yeah.
some space to push
Yeah.
through our needle.
Yeah, absolutely. And then I will park it on the bladder before I tighten all of this. So again, from here, what we do is you can, let the catheter be back. Don't pull it. So this is not the first one, but because I've done a continuation from the Rocco, I will tighten that. But I don't bother too much if it doesn't tighten completely, because the next one is the one that actually tightens it. So you see how the whole thing has come together there. And this is more of a cinching movement, what we say, rather than a pulling movement. So you're cinching it to the urothelium. Right, catheter in, please. Yeah, so that'll go in there.
For the audience, a small trick that we use during
Catheter back.
anastomosis is that whenever a mucosa tends to retract in the bladder, it's very difficult to take that mucosa and do a mucosal to mucosal anastomosis. So what we do, what we teach our fellows is that 1 or 2 sutures we can take at the level of the bladder to just invert the mucosa at 1 or 2 places, so that you can just
Absolutely.
hold the suture and take the bite.
And so you can also see the other thing with the other tricks. So when you do the anastomosis, you're not always just using your right hand. And then this is, if you play tennis, right? This quadrant and this quadrant. So left upper quadrant, right lower quadrant. I'm going to use my right hand. Right upper quadrant, left lower quadrant. I'm going to use my left hand. That's how you get the proper angles. So because now I've switched from doing down to up. I'm going to go with what's called a right hand, backhand. Yeah, catheter in, please. That's good. Catheter back. Say again. That's a good point.
We've
Very
not
good.
taken the bladder.
Thank you for being awake while I was sleeping. Not that I'm sleeping, but yes. So the angulations for the 5/8 are slightly different from the half circle needles. And the wrist movements are also slightly different. Yeah, catheter in, catheter back. So again, so what I'm going to do is I'm going to engage mucosa and I'm going to pull back. And that will make sure that I don't get too much of urethral muscle. What I'm actually getting is mucosa. Now before I pull that, I'll pull the previous one to lock all my previous sutures. And then I'll pull this one to make sure it is watertight. We don't want it to be airtight, we want it to be watertight. So what I'm going to do is I'm going to just leave this here. Yeah, let's get the other one, please.
Any questions from the audience?
So Tushar has very kindly asked me
I
to-
think the moderators are doing a very good job of explaining everything even before the questions crop up.
Absolutely.
So that's why we have very less questions. Madhav and Kinju are on it like fire.
Maybe the moderators from the hall are doing the better job.
Yes, maybe we are not hearing and they are explaining everything to them.
तुम सब कुछ पहले से ही बता के रख देते हो ना बस.
Now what Kinju said was, I think, better.
Yeah, that's true, but take some credit.
So the other thing with V-lock sutures, in my experience, you have to go back on where you have put the knot. Otherwise, it slips. So I'm taking it twice on the bladder to get the loop outside. Because you see where that loop is, that stays loose unless you do this. Catheter in, please. Yeah, that's fine. Don't worry. Yeah. And this is again what I said about right lower quadrant, using my right hand.
So Ashwin, the first suture that you took just right now,
Yeah.
that's going through the anastomotic line. So was it deliberate or
What's going through the anastomotic line?
the across the anastomotic?
So he has gone back on himself so that the knot goes.
Yeah.
So that the knot
outside.
goes outside. Otherwise, the knot comes inside. Yeah.
What do you do if you ever face a situation where you're doing this in and out, or maybe a last bite, and you've caught the catheter?
So what I tend to do is I push the catheter in and pull the stitch through the catheter, so I don't mind damaging the catheter as long as it's not remaining in the bladder. But I don't want to continue stitching without knowing that I've caught it. But to be honest, it's quite difficult to catch the catheter with a half circle. So now again, so like I said, left upper quadrant, right lower quadrant, I'm going to use my left hand backhand suture. The slight disadvantage with the half circle needle is it's a little bit trickier to go through and through. With the 5/8, you can go quite easily through and through.
So you
Yeah.
always do with 2 needle drivers, right?
If I can, yes.
Yeah, because this particular throw of the needle,
Yeah.
Cannot
the
be done
11
through-
o'clock.
Yeah.
So you're doing it beautifully because you're doing it with your left needle driver.
Yes.
Now this was a point, I'm just saying it, was the most difficult part of my training because my boss used to use only a right-handed needle driver. So you had to go in and sort of take it in a, facing up, a movement which he had mastered, but which I took a long time to do correctly.
Was that
So-
Declan?
Yeah,
Or
yeah, Declan.
I'll tell him off.
Yeah, so he does this particular throw with his right hand.
Yeah, he was a
sort-
laparoscopic surgeon, that's why.
Yeah, sort of facing back and up.
Yeah.
He started his career with laparoscopic prostates.
So again, with the right upper quadrant, I will try and do it with my left hand.
Yeah, yeah. This is easier and a much better way of.
How will you manage
So past the midline, I'll go, let me see if I can go through and through. So even if I'm going through and through, actually I want the needles quite small. So then I can use, but what does he use in his left hand? Is it a Maryland?
accidentally you have told it to your
Rahul?
and he has forgotten?
What does Declan use in his,
It was always a Maryland.
yeah, so that's the problem. If I don't have 2 needle holders, I would probably change to a fenestrated bipolar rather than a Maryland, just to have better needle grip.
So as you're finishing up, just a couple of questions. What is the size of catheter you use?
Yeah.
Your thoughts on when do you remove the catheter?
Yeah.
And your thoughts on not having a catheter and having an SPC in place?
Those are all very, very good questions. So when I do a Retzius, by default, I put an SPC. And
Could you say that again, please?
when I do a Retzius sparing approach, by default, I put an SPC, and I take the urethral catheter out the same day. The SPC is on a flip flow valve, and the patient is voiding from day 1. But what they do is they cycle the bladder. So every 3 hours, they have to open the SPC to see if they're retaining urine. And if they're not retaining urine, then they don't have to do much. During the night, I tell them to, so here again with the anastomosis, I always cross it. I don't leave it sort of by itself. So then they cycle it, and then after 5 to 7 days, they are usually free of the SPC. They don't really have a urethral catheter for very long. They're very, very happy.
So if I'm getting this right, you remove the catheter on
The urethral
post-operative
catheter.
day 1.
Absolutely, the same day of surgery.
Okay.
Not a post-op day
then
1, same day of
why
surgery.
only? Why do you only do this for patients with Regis pairing? What is different? Why couldn't you do this for a case like this?
So let me just tell about this stage and then I'll get back to your answer. So what I've done now, I'm on the urethral surface. So I'm not going to come back to bladder and go here because that will kink. So what I'm going to do is from urethra, I'm going to go here. And that, you see how it supports the urethra, keeps it inside the abdomen. So the reason I don't do it for anterior prostates is to get the SPC in, you have to incise from outside to inside. There is an increased risk of bleeding and hematuria, so it defeats the purpose of putting the SPC in. Whereas if you do it retius, you don't have that risk of hematuria, and then you can do it quite easily. So can we test to make sure the bladder is going in and out okay? So the catheter is going in and out okay? Does that answer your question? And in terms of standard, so in this gentleman, I'll leave it to Tushar's normal protocol as to when he takes it out. He doesn't need a cystogram because I will now test to 300. So can we have 300 mils ready to test, please?
And do you think the size of the catheter has any impact?
The smaller the catheter, the better. You don't really need a big catheter. You're not expecting a hematoma to form. This is not like a TURP. You don't need a three-way. You don't need any of that. So a 16 French is fine. You don't really need too big a catheter. Absolutely, you can. I'm used to bending the tip of the needle before we take it out in a 5/8 needle, because through a 5 millimeter port, it doesn't come out. It tends to catch. But I forgot this is a half circle needle, so I don't need to do it. So is there any different practice in terms of urethral catheters and timelines?
No, I remove it on the 5th day,
Okay.
unless there's a Sunday. But I've moved to a smaller size. I've moved to 14 and recently sometimes to 12. I think they're more comfortable.
Absolutely.
Especially as we're sending them home the same day or the next day.
Yeah.
Sometimes I've put a 12. Most of the time it's just a 14.
How do you manage post-operatively to get them early continent? What medication if you give?
So what was that question?
The question is, once you have removed the catheter,
Yeah.
now the patient is having a incontinence for
Okay.
for a few days.
Yeah.
So how will you treat them pharmacologically?
So the evidence from the IMPACT trial showed that there is absolutely nothing you can do to treat the stress urinary incontinence after prostatectomy. The only thing you can treat is if they have urgent continence. So if it's obvious urgent continence, as some patients do have actually, then you can obviously give them anticholinergics or beta-3 agonists or whatever is standard of practice for you. But surgical technique is the only predictor for early return of continence. So you have to do a good operation for them to be continent early. Usually men tend to adjust to their levels of incontinence, and after a year, if you ask them, are you using pads? Most of them, don't want to wear pads. They say they're not using pads, and people take it as sort of pad-free, but it's not really leak-free. But there is a trial, so there is no pharmacology that helps unless it is urgent continence.
So I think what I do is put them on some kind of lifestyle advice. They all go home with an instruction that for the next 1 to 3 months.
One question from the audience. What is your protocol for putting the drain, sir?
I don't put a drain.
We also stopped putting drains. So
you are not
it's
doing
been
lymph node, you're
2-3
not
years that we
I mean,
also
even if
stopped.
I do lymph nodes, I don't put drains. Because so the thing is, what are you getting out with the lymph node dissection? You are getting out lymph, and that's heavy in protein. So you don't really need to put a drain in. But the thing is, I've had one patient out of the 2,500 cases I've done who had an infected lymphocele, but that was post-cystectomy. And for him, we had to put a drain afterwards. Because even for my cystectomies, I don't put drains in. Unless they're neobladders. Neobladders, I'll put drains in.
So what is your thought on penile rehabilitation after the catheter is removed, sir?
Yeah, very, very important. So early removal of catheter. Is the final catheter in? Final catheter is in? Okay, let's do a leak test of 300, please. So you see, we've done all the steps of so we have done the preservation, we have done the bladder neck, membranous urethral length, bilateral nerve spare, posterior reconstruction, anterior reconstruction. So hopefully, it should be fine.
So regarding the drain part,
Yeah.
even if we have done a bilateral extended lymph node dissection, also we do not put drains.
Yeah,
We've
I don't put
stopped
a drain
putting
in.
drains long ago.
Yeah. I don't put a drain even for bilateral lymph node dissections because, like I explained, all you're doing is getting lymph out, which is actually protein that the body needs. So there's no point in doing that unless it gets infected, and the risk of infected lymphocyte is really, really small.
Dr. Shridhar, I have found that the patient whom we put the drains, in the postoperative period, they generally develop a hypoalbuminemia.
Yes.
So if we don't put the drain, then there will be no risk of hypoalbuminemia?
It is reduced. It's not that it's not there because there's still third space losses, but the hope is that the body absorbs it. How much is there in, please?
Because that do contribute to some amount of ileus and some amount of maybe prolonged ileus.
Ileus post-prostatectomy.
After, if you are showing that their serum albumin levels are coming
Low.
to 2.3, 2.4.
Yes. Again, yes. So that's again why I don't put a drain in.
Yeah.
Unless you're forced to do it. Say that again.
So
250. So 50 more than, please. So no clips, no hemostats. Yeah. Happy?
Yes,
Tushar, happy?
Wonderful operation.
So wonderful surgery. We enjoyed it a lot.
Thank you.
Tushar, have you recorded this?
Yes.
Yeah. So all of us want a copy of this.
Yeah, so it's recorded with the discussions. So all of you would get the copies with all the questions and all the discussions also as the surgery was going on. So not just the surgery, with the whole live discussion, it has been recorded.
So another trick, I don't know, Tushar, were we doing this when you were there? To close the port from the inside? Yeah. So let's get the specimen through.
Dr. Tushar. Hello.
Yes.
Dr. Tushar, if like we are checking a leak here, if let's suppose there is a leak,
Yes.
Yeah.
what would we do then?
We would try to repair it if we can see the leak. If we can get some sutures, almost 99.9% we should be able to stop the leak with a reinforcement suture. In case you're not able to find it.
No, okay, you've got that.
Yeah, in case
It's very unlikely that you would have a leak where the water is just welling up.
Yeah.
You would see something minor trickling along the sides, and then you go close there and you try to put sutures around the periurethral tissue and see if it helps.
If there is a minor leak,
you can leave it, the catheter will take care of it,
Leave it on catheter.
but nothing will happen, but try at least once so that you can take